Hello, my name is Callie Sullivan. I'm at Grand Valley State University, and I will discuss investigation of injuries due to cardiopulmonary resuscitation. Cardiopulmonary arrest is when the heart ceases to function, which may result in death. Cardiopulmonary resuscitation, which is CPR, is performed on a person to possibly regain heart function, allowing for survival. CPR is done by placing compressions onto a person's chest to create an artificial mechanical heart rhythm, allowing for the blood to be pumped throughout the body. Performing these compressions onto a chest can cause rib fractures, pneumothorax, lacerations of organs, bleeding into the chest cavity, and other problems. While the chest compressions are being done, the brain might not be receiving enough oxygen, resulting in neurological deficits as well. Only about 7% of people who receive CPR survive and are discharged home from the hospital. Actually, in the 1950s, physicians tried to rule that CPR was too dangerous to be performed due to these problems. My project is going to look into the physical damage that was done to the cadaver due to CPR. In lab, we examined a body that had chest compressions done before death and examined the physical damage that was done on the body while the chest compressions were being performed. I dissected a 96-year-old male using Grant's dissection, and upon the dissection of the anterior aspect of the external thoracic wall, there was multiple rib fractures noted on bilateral sides of the chest. The cadaver was carefully dissected to open the chest wall to examine for any other injuries. The chest wall was reflected inferiorly to examine the posterior aspect of the ribs. Usually with rib fractures, they also result in other injuries like I was talking earlier, like the pneumothorax, laceration of the organs, and other problems. So more examination was carried out to the cadaver to look at the other injuries due to the rib fractures. I examined the lungs and internal organs to look for those injuries due to the rib fractures / chest compressions. After full examination of the 96-year-old male cadaver, there were 4 rib fractures on the right and 3 rib fractures on the left, totaling 7 rib fractures. Up on figure 1, you can see the external view of that chest wall, basically the first view I had of his chest. You can see right there from the arrows, that's where you can see the rib fractures in the picture. So you see that there is bilateral rib fractures on this person, this 96-year-old male. And then in figure 2 there, this was after we reflected the chest wall inferiorly to look at that posterior aspect of the rib fractures. You could see them a lot more this way. And the arrows are pointing to those rib fractures. This is on the right side of the internal chest wall. You can see 4 fractures from the picture. And then you can see that there's one really bad one right there that could have possibly caused a laceration of the organs or a pneumothorax. And then figure 3 right there is that basically a backed up view of figure 2. So you could see the left side as well. The arrows are still pointing to where I saw the rib fractures just from the picture. In lab, you could see you could actually feel the ribs where they were broken. You could also see them popping out a little bit more than these pictures. The pictures don't do as much justice for what happened. And then also you can still see, compared to the left, the right side seemed to have a more severe breaks. They also had one more break compared to the left. When I removed the chest wall and I looked inside him internally, into his lungs and his other organs as well, like the liver and the stomach, there was no observable internal damage due to the chest compressions or rib fractures that I could have seen on this cadaver. In conclusion, in 1958, a man named William K. I'm not going to pronounce his last name correctly, so I'm just not going to pronounce it, published a paper discussing the possibility of other non-traumatic resuscitation attempts for restarting normal heart rhythms. This article allowed for multiple physicians to look at the damage that was actually being done by chest compressions on cadavers. which resulted in finding those findings like I was talking about earlier, the rib fractures. They found ruptured livers, pneumothoraxes, fractured sternums, bone marrow emboli, severe hemipericardium, ruptured blood vessels, and much more. These results were what the physicians argued that CPR was causing too much physical damage to be continued for life-saving measures. With my cadaver that was examined in lab, I only observed multiple rib fractures that were due to CPR used on him prior to death. Rib fractures can result in other complications like pneumonia, effusions, acute respiratory distress syndrome, which also all increase morbidity and mortality rates in the elderly. These complications from CPR could be detrimental to elderly patients who already have disability prior to CPR. But even with these physical damage that were presented in this poster, hospitals are still required to do CPR unless documented proof that the person is DNR, which means do not resuscitate. If a person is mentally capable of declaring that they want to be DNR, then they have the right to deny CPR and chest compressions and all of these problems that could be caused by chest compressions. Even a power of attorney can also be able to declare DNR on a person if the person is not in their right mind. A person who is in cardiopulmonary arrest should always just receive CPR because unless there's proof that a person is DNR, because physicians have the right, have the predisposition, to sustain life, even if the outcome is uncertain. If physicians made the mistake and didn't perform CPR on a patient, there is no reverse to death. So CPR is going to be continued to be performed.